A very warm welcome to everybody. And we are about to begin with our second session, right? So I think we have Dr.
Yes, Mr.
Mehul is already
Himay,
here with
Dr.
us.
Dr. Tanmay is starting.
Yes,
He is the first speaker of this session.
right. So, Chairperson, if you can invite Dr. Tanmay and we can.
Yeah, Dr. Tanmay Biswas, please,
Yeah.
you can start your topic.
So is my screen visible?
Yeah, visible.
Okay. So first of all, thank you to everybody for inviting me. So I'll be talking about the scourge of retinoblastoma, and I have no financial interest to disclose. So coming to the retinoblastoma is one of the life-threatening causes of leukocoria. We all know that, and retinoblastoma is one of the most common intraocular malignancy in children. So the reported incidence ranging from one in 15,000 to one in 18,000 live births, second only to uveal melanoma in the frequency of occurrence in malignant intraocular tumors. So there is no racial or gender predisposition. It is usually bilateral in about 25 to 35% of cases, and the average age of diagnosis is usually around 18 months, whereas in unilateral cases it's 24 months, and bilateral cases it's around 12 months. So the incidence of unilateral non-heritable disease is increasing, especially in developing tropical and subtropical countries. There are various theories as to why it is happening. Some authors state that it could be due to viral etiology. Some could state that it could be due to dietary influences in pregnancy, but it could also be due to better diagnostic and screening procedures. So coming to the genetics, so the newly diagnosed cases usually 6% are familial, whereas 94% are sporadic, whereas bilateral retinoblastoma usually germline mutations in all cases. Around 15% of unilateral sporadic cases caused by germline mutations affect only one eye, whereas 85% are sporadic. So here in this chart, there is around showing the distribution of cases of chances of occurring in different population if or if the parents do or have retinoblastoma versus if they don't. So as you can see, people who there is higher chances of having if there is a positive family history. So this chart shows the various modes of presentations of retinoblastoma, leukocoria being the commonest, followed by strabismus and red painful eye. So the reason, so in a children in the first, it can present retinoblastoma present in various ways. So whenever we are seeing a child, we have to keep this in mind. So while coming to the examination, it has to be has meticulous history taking because the child usually is very uncooperative, and visual acuity measurement has to be done very carefully, and thorough examination including in fundus exam. We have to make sure if possible we have to also take photos, and if sometimes if the children is not very cooperative, we have to examine under anesthesia, because the examination of the entire retina, especially up to the periphery, is very important. So it is also very prudent to evaluate the siblings and also the parents if possible in the same setting, and if not, then as soon as possible. So coming next to the imaging, so ultrasound should be done for both the eyes. To sometimes very small tumors in the periphery, we should not miss them. So MRI is a very important investigation on to assess orbital as well as extraorbital extension. It is very sensitive in distinguishing between other forms of leukocoria. Currently, it is one of the investigations of choice. So CT scan is not very advisable nowadays because MRI is ubiquitously available. So if MRI is not at all available, so we may thinking about CT scan, but usually MRI is more preferable. So we need to do invasive tests like lumbar puncture, bone scan, PET scan to rule out METs. So the goals of the treatment are usually the first one is to save life, second the save salvage of organ and dysfunction, and the tertiary one is the avoidance of side effects. So it requires a multidisciplinary approach along with the pediatric oncologist, the radiation oncologist, and oculoplasty specialist, the retina specialist, etc. So the treatment option will quickly go through that. The sort of main are the focal treatment, the chemotherapy, and the enucleation and the external beam radiation therapy, which is not usually not used very commonly nowadays. So focal therapy can be cryotherapy, which is usually done at 4 to 6 week intervals, and it can also be used with intravitreal chemo to reduce iatrogenic tumor seeding. So the complications can be transient serous RD, retinal tear, and large scar. So another forms of focal therapy is the transpupillary thermotherapy used with a diode laser, causing cytotoxic effect to tumor cells due to heat, and combined with chemoreduction for larger tumors, complication can be focal iris atrophy, peripheral cataracts, retinal traction, and RD. Another forms of is plaque brachytherapy, implantation of radioactive material on the sclera of the base. It can be done with iodine 125 or ruthenium 106, and the complication in use include radiation retinopathy or optic neuropathy. Chemotherapy can be used in various ways, that is intravenous, intraarterial, intravitreal, and periocular. So intravitreal chemotherapy is usually two, three, or four drug combination regimens. The common drugs that are used are carboplatin, cisplatin, etoposide, cortican, etc. Adverse effects like other chemotherapies is usually bone marrow suppression, neurotoxicity, hyponatremia, nephrotoxicity, etc. And another is the intra-arterial chemotherapy. It is a very target-specific chemotherapy. So that drug is usually delivered to the ophthalmic artery. So the advantages are reduced amount of drug required, and the side effects are reduced. So has greater success rate compared to intravitreal chemotherapy, which has been seen in different studies. But the adverse effects are vitreous hemorrhage, BRAO, ophthalmic artery spasm, ophthalmic artery obstruction. But what has been noted by different authors is that the most complication reported with intraarterial chemotherapy is usually related to the technique. So properly done intraarterial chemotherapy has really got very minimal adverse effects. So enucleation is one of the gold standard therapies for advanced intraocular retinoblastoma. So we have to cause minimal globe trauma while doing it, a long optic nerve section, histopathological examination, of which if shows scleral invasion or orbital extension or cut-end of the optic nerves, we should treat it like orbital retinoblastoma. We have to take steps to prevent bony deformity in the form of orbital implants, along with the oculoplastic surgeon, so that when the child grows up, the orbit is not really a contracted socket. So external beam radiotherapy is not really used nowadays. So it's the last resort for globe salvage prior to enucleation. Complication can be mid-facial hypoplasia, etc. So prognosis is usually very good if treated before extraocular spread. Degree of optic nerve spread greatly changes chances of survival. Distant site metastasis carries poor prognosis, whereas pinealoblastoma has a very poor prognosis. So there is a controversy regarding cataract surgery. Different authors have said this is a very safe procedure, so you can approach it in any way, but it has to be done in a period of inactivity. Some authors suggest a minimum of 16 to 18 months of inactivity after that. Posterior capsule removal to be done on case-to-case basis, and follow-up is usually first 6 months, 4 to 6 week interval, 3 years, 4 to 6 monthly intervals, and later yearly. With a positive family history, all members should be examined yearly. Genetic counseling is very helpful, can detect exact mutated gene, can also use in siblings and parents to detect germline mutations. So the take-home message is keep an index of suspicion, as it can present in any manner. Refrain from unnecessary invasive procedures. For example, do not drain a hyphema without investing, or a vitreous hemorrhage, and timely referral, follow-up, and coordination with the oncologist. Retinoblastoma is one of the most curable pediatric cancer. Thank you.
Thank you so much, Dr. Tanmay,
Thank
to
you very much.
Yeah. Thank you.
bang on time. May I now request our chairpersons to please invite the next speaker.
Please, Parikshit sir. May I invite Dr. Himay Lakhani to present his next speech.
All right. Do we have Dr. Mohini with us? Dr. Mohini, could you please unmute yourself?
Yes, sir.
Yeah, Dr. Mohini Sarastabudde is going to be our next speaker. Ma'am, you can share your screen and you can start with the presentations. Thank you.
Yes. Am I audible?
Yeah.
Yes, doctor, you're audible.
Yes, you are audible. You can start.
So after having performed a surgery in a pediatric cataract, is our job complete? So not really. So good afternoon, everyone. I am Dr. Mohini Morak, and I'm going to be talking about what after cataract surgery in a child with in a child. The post-operative rehabilitation in a child requires a concentrated effort over many years of the parents, ophthalmologists, optometrists, schools, etc. The role of parents here is pivotal. It is important to make them partners right from the process of planning to the surgery to the post-operative medicines, and their compliance and the extra effort that they take may improve the chances of success in the child. The recovery room in these cases should be well equipped with, and also have trained personnel who can take care of the eye as well as the child. In the immediate post-operative examination, care should be taken to note of the inflammatory reaction, as children tend to have stronger inflammatory reactions. This should be controlled with an antibiotic steroid combination tapered over 6 weeks. The dilatation should be maintained with atropine in younger children, and older children, humide is sufficient. Systemic steroids can be given in those cases where severe inflammatory reaction is anticipated, like in traumatic cataract. In cases with complication, should be reviewed every weekly until an improvement is noted. The first follow-up for an uncomplicated case should be around 2 to 4 weeks, a little later for the pseudophakic children. If possible, the child should undergo refraction and the glasses dispensed at this very visit. In a pseudophakic child, it is important to mention to the parents that the surgery will not eliminate the need for glasses and frequent changes might be necessary. Any residual refractive error, especially astigmatism, should be corrected. Below the age of 2 to 3 years, single vision lens with a near focal point of around 50 to 60 centimeters is sufficient. However, above this age, a bifocal segment should be added. Flat top D-shaped or executive bifocals are preferred in children. For aphakic children, contact lenses are the preferred mode of treatment, especially since the 1 month extended elastomer lenses, which can be left in the eye for a month at least. Rigid lenses need to be instilled and removed every day. Where contact lenses, spectacles have to be utilized. The universally preferred material for this is CR39, as it is plastic and hence lighter. However, these thick lenses are going to be heavy, so smaller frames should be preferred. In unilateral aphakia, contact lenses are the preferred modality. However, where that is not possible, spectacles will have to be utilized in spite of the anisophonia, at least during the period of amblyopia treatment. Longer-term follow-up should take place every 3 months up to the age of 2 years, every 6 months up to the age of 5 years, and yearly thereafter. Now, this is much easier said than done, and studies have shown that the follow-up rate in pediatric cataracts is as low as 20%, especially in a country like ours where there's a lot of rural population. The most common complication occurring after pediatric cataract surgery is amblyopia, which is almost to the tune of 40 to 50%, followed by visual axis opacification and glaucoma. In a prospective study done by the Pediatric group, they found that at the end of the very first year, almost 51% of the children had some amount of amblyopia, more in unilateral aphakics and least in bilateral pseudophakics. Thus, in a unilateral cataract surgery, the treatment for amblyopia should start right from the time of the surgery till at least 8 years of age. Many children with bilateral surgery may not require amblyopia therapy. Occlusion is the preferred modality for treatments. Almost 17% of the children undergoing pediatric cataract surgery will require a secondary surgery, the most common cause for which is visual axis opacification, followed by secondary IOLs and then glaucoma surgery. If the PC is left intact, the visual axis opacification is almost uniform at 100%. Where PCC is done without an anterior vitrectomy, the rate decreases to 60%, and it further reduces to 10% if at the time of the surgery, the PCC is combined with anterior vitrectomy. However, if the visual axis opacification does develop, YAG laser capsulotomy should be done wherever feasible. Where not, or where there is a recurrence, a membranectomy will have to be performed. Those children who are left aphakic at a young age group and are suitable for them, secondary IOL should be performed at the age of around 2 years. K-Meta reported that with the placement of the IL after the age of 2 years, the vision improved to a median of around 20/50 in 44% of the cases. However, the most common cause of visual loss despite a successful cataract surgery remains glaucoma. It is acute in the early postoperative period with pupillary block. However, the most common type of glaucoma in these children is an open-angle glaucoma. The problem here is that unlike congenital glaucomas, they do not present with epiphora or Habs-Tribe ophthalmos and tend to be asymptomatic in spite of high IOPs. Also, the routine examination of IOP, visual field, and the optic disc evaluation is difficult and sometimes impossible. Thus, a high index of suspicion and maybe repeated EOAs will be required to clinch the diagnosis. Unlike congenital glaucomas, the management primarily here is the medical therapy with beta blockers, carbonic anhydrase inhibitors. Even pilocarpine has a role in, especially in aphakic children. The success of filtering surgery has improved with the use of antifibrotic drugs like mitomycin C. However, there is the risk of endophthalmitis. For those who do not, even the trap fails, glaucoma drainage further improve the chances of management in a glaucoma patient. Cycloablative procedures are reserved for those children who have a low visual potential. Thus, it is important to mention that diagnosis of glaucoma following pediatric cataract surgery requires a lifelong surveillance and a continuous assessment of the problem. This re-stresses the main issue that a long-term follow-up, which unlike adults, which is only 4 to 6 weeks, here's a long-term follow-up over many years, is very important in these children. The MIRROR study found that 92.7% of the children required some kind of a clinical intervention during a prospective follow-up visit. So, and not only that, 38.8% of these eyes gained more than one line of visual acuity due to these interventions. So, to conclude, alongside a good quality care before and during cataract operation, a careful post-operative care and long-term follow-up are essential for a good outcome in children undergoing cataract surgery. Thank you.
Thank you so much, Dr. Mohini, for your wonderful presentation. Now, I would request our chairpersons to please invite our next speaker for the presentation. Thank you.
Dr. Supriya is available? Dr. Sujata, please. Can you start your presentation?
Yes, I can.
Yeah, please.
Yeah. Can you see my presentation?
No. Yes, please.
Yes, we can see.
Yes, now it is.
Okay, just one. My slide is not moving. Just give me 2 minutes. I'll just stop sharing and I'll just check once. Okay?
Yeah.
Maybe you can ask somebody else. Let me check once again why my not.
Dr.
Okay,
Sucheta.
I think I have got it now. Let me just start sharing once again. Can I do that? I'll just start.
Yeah, please.
Yes, doctor, you can give it a go. No problem.
Yeah, thank you.
Perfect, doctor. We can all see screen now.
But I don't know why it is not moving. I'm not very sure why.
Doctor, is this a screenshot or is this the presentation from which you have started?
No, this is not a screenshot. It's my presentation.
So I think there is some issues with your system. You may restart it by the time other person can
Yes,
come.
yes. Please.
So, chairperson, can we invite the next speaker, please?
Yeah. Dr. Sucheta, Dr. Supriya, who is available?
I think
Yeah.
Dr. Suchita is there.
Yeah, I am there.
The doctor.
Yeah, then you may start.
Okay. Can you see my slides?
Yes, doctor, we can see your slide. If you can just bring it to the full screen, that
Yeah.
would be great. Perfect, doctor. You can go on now.
Yeah. So, good afternoon, everyone, and thank you, Chairperson, for giving me the opportunity to be speaking on operating in a child below 8 years. So, I have no financial interest in this presentation. Any opacification from the birth or early childhood is defined as a congenital cataract, and even though it is rare, the prevalence varies around 4.24 per 1,000 population, and it is one of the most common treatable cause of childhood blindness. So the question comes, why do we need to operate? We all know that pediatric cataracts have to be operated, and when the question, big debatable question is, when do we operate these cases? So coming to the pre-verbal children, as we all know, the dense cataract, which is blocking the red reflex with a dilated pupil, or if you are seeing any signs of strabismus with unilateral cataract, or you are having an nystagmus, which is accompanying bilateral cataracts, then we have to operate in those cases. Beach et al. Have reported that pediatric unilateral cataracts should be operated between 6 weeks and a bilateral cataract before 8 weeks. So the timing of any lens aspiration is critical in congenital cataracts to prevent deprivational amblyopia. So how do we go about it? The most important thing is about the pre-operative workup. So most of the pediatric cataracts can be idiopathic, 33% of them can be idiopathic. What is important is you have to have a good neonatal history, family history, and the type of cataract you are dealing with, because it is very helpful to give you recommend the laboratory workup which you have to do, because unilateral cataract doesn't need much of investigation except the general anesthesia. But bilateral cataract needs investigations in the form of, you have to have a torch profile, you have to have a CBC, you have to have serum urea creatinine, and if needed also you have to ask for this urine analysis for reducing sugars or galactokinase, calcium, or phosphorus. And if you are seeing a dysmorphic baby, then you have to have the genetist to work it for you. Now, very important is examination of the eye before you take up for surgery. So you can do a handheld examination, always very important, rule out, see the red reflex and see how the reflex is looking, whether you have any associated things along with it. So whether you are dealing with a healthy child or with a diseased child, that is very important and you should be taking care of. So look for any strabismus, microphthalmus, microcornea, any signs of uveitis or PHPV, and how is the pupillary reaction, and look at the type of the lens opacification. So there you can land up in having different type of morphology of the cataract. It can be a blue dot, it can be a lamellar, it can be a membranous. Even if an elder child can come to you with a traumatic cataract where you can see so much of cortical matter in the anterior chamber with the lens breached in those cases. So fundus examination is a very must in all of the cases, and if you are having a total cataract where you cannot see the fundus, then you have to take the help of the B scan, where you have to look for any vitreous hemorrhage or vitreous opacification or retinal detachment before you take up these cases for surgery. What is important to know is what is this normal pediatric eyes are. We know that at birth, the axial length, the keratometry, everything is different from what it is there in cases of adults. And there is a rapid growth of all these ocular biometrics within the first 3 months, and there is a slow growth for next 15 years, sorry, not years, it's 15 months. And so why it is important to know, because the lens, intraocular lens, which we are going to place in those cases has to need under correction accordingly. So you can follow the rule of thumb to have a post-operative target refraction in those cases. So we usually say what is important is, like if you are between 2 to 4 years, spherical equivalent of the fellow eye minus 1.25 diopters, and above 4 years, the spherical equivalent of the fellow eye will do But what is important, if you are, you can do a 20% undercorrection in infants and 10% in the toddlers of what the intraocular power you are going to give. So these are some of the studies which has recommended the post-operative refraction, what intraocular lenses your emmetropia you are aiming at, and the Dahan's formula can be used in most of the cases. Coming to the per se of when we are doing a surgery in these cases, what is important? Pediatric cataracts are really challenging because they are not like the adult cataracts. First and foremost, very important is the incision which you are doing. Either you can do a sclerocorneal tunnel or a limbal or a clear corneal. Now, it also depends on the age of the child which you are taking up, but the most important thing is the management of the anterior capsule, because they are more elastic and it is very harder to control the direction of them, and to get an optimum size and shape of this, it's quite important. Till now, manual capsular access is still the gold standard for a successful outcome in the pediatric cataract age group. General anesthesia is very much important. Most important, before you start, you can do the measurement. The corneal diameters should be measured in most of the cases. And if you have an array of lens with you, you can do a handle autokeratometry over there, and you can do a calculation of the intraocular lenses if you have not done pre-operatively. Most important in this cases is you have to give a trypan blue in most of the cases after you have done incision or limbal or clear corneal or a limbal incision, and this helps you not only for visualizing the anterior capsule, but also helps you to prevent the radial tears when you have when you are doing a capsular excess. So most important is either you go about with a cystitome or a atrata forceps to do a complete continuous curvilinear capsular excess, which is a must in all cases of pediatric cataracts. Very important in these cases, you have to give high viscoelastic in all of these cases. I'll be just showing in a video. And you have to make a smaller excess, and then you have to keep on continuously moving and removing, so that you have a centripetal type of your move should be there, so that you get a good rhexis in those cases and you don't have a runaway rhexis. Rhexis of the forms where you can go ahead and help to construct a good capsular rhexis in this case. Now, foldable template intraocular rings are there, which also help, or Gypto is one of the alternatives which can help you in making a good rhexis in those cases. Now, what is important is after doing a good rhexis, you can go about do a lens aspiration. In those cases, you have a phaco aspiration and you can do it. That is not much of a difficulty. But what comes after is how to go about doing a posterior capsular rhexis in most of the cases. Of a children who is below 4 years, we have to do a PPC along with anterior vitrectomy. But if a child is more than 6 years, you can just do a PPC and not go about doing an anterior vitrectomy in those cases. Now, capsular rhexis again in PPC can be done either manually or with the help of a vitreorhexis in those cases. But the size should be smaller than the anterior capsular rhexis, so that allowing the intraocular will have a lower opacification. This is my video. Just I'm going about doing a fill up with the high viscoelastic and heal on GV in most of the cases. We are looking at you start with a small atrata forceps and you do a smaller rhexis. After that, you do a hydrodissection properly and you remove the soft lenses, so you can very well remove them up, and then you can do a bimanual method of removing the entire cortical matter. That is very important. All the cortex should be removed because we don't want to have a post-operative opacification in most of the cases.
Sorry to interrupt, doctor. If you can just sum it up, please, because the time is up.
Yeah,
I'm so sorry.
This is my last anyway. Okay, can you see the slides?
Yes, doctor, if you can go to the concluding.
So what is important is we have to give a suture at the end of the surgery. So this is just a thing of leaving them aphakia or giving a intraocular lenses, and most preferred intraocular lenses which we are giving nowadays is a hydrophobic acrylic IOL. So post-operative complications, what we come up is already taken up by the other speakers, so I'm not going into details. So take-off message is very important. Pediatric eyes are not miniature of adults' eyes, and meticulous planning is very much needed, and challenges during CCC should be taken care of, and long-term follow-up is needed in most of the cases. Thank you.
Thank you so much, Dr. Sucheta. May I request our chairpersons to please invite the next speaker. Thank you.
Dr. Sujata, are you ready now?
Sir, I called up Dr. Supriya. Her family is admitted for COVID, so she says she can't come now.
Okay. But
So,
Dr. Sujata is ready now.
One speaker is not there. Yeah.
So, Dr. Sujata, are you ready with your laptop?
I think, sir, she is log out.
Sir,
Okay.
Dr. MEHUL, Dr. Taranum is also here with us. And
Yeah,
she also
we
has
can start, Dr. Taranum.
Am I audible?
Yes, ma'am, loud and clear.
Yeah, yeah.
Okay. Are my slides visible?
Yes, doctor, and if you can go full screen, that will be great.
Okay. So I'm going to discuss pediatric cataract management in age more than 8 years. Pediatric cataract in age more than 8 years are usually congenital with delayed presentation, or the juvenile cataract which develop after infancy, and these cataract have good visual outcome after cataract surgery, or they are the acquired cataracts. Juvenile cataract present with myriad of morphological pictures, and surgical planning is often based on the morphology. Traumatic cataract and the uveitic cataract are important acquired cataracts. The indication for surgery in older children is size more than 3 mm, a distorted retinoscopy reflex, vision less than 20/40 if the patient has problems in the classroom. Here is a picture of a unilateral anterior polar cataract with vision of 20/25, and no surgery was indicated in this case. The objective of surgery is to clear the visual axis by removal of the cataract and focusing of retinal image by placing an IOL plus minus glasses. The problem is that the eye is small, the anterior capsule is elastic, the scleral rigidity is low, there is increased vitreous pressure, the anterior chamber is unstable, and there is difficulty in calculating IOL power. Surgery is therefore technically more demanding, and post-op inflammation is high. The younger the child, the more marked are the differences. The infrastructure required are the equipment for the IOL power calculation, like the A-scan and the keratometer. Handheld keratometry is only required if we are planning under GA. Children more than 8 years cooperate in biometry, and therefore IOL power can be estimated prior to surgery. Formula found to be more predictable are the Holiday 2 and the SRKT. Method of choice is the optical biometry or the immersion biometry. GA backup, cutter, and microsurgical instrument are required. Anesthesia in older children, local anesthesia can be given in cooperative children, especially in the developing countries where GA is a big problem. Cooperation can be judged while doing the biometry and other procedures in the OPD. Globe size is bigger as compared to the orbital volume in pediatric population, so peripalpal block should be given carefully. The other option is LA with sedation and general anesthesia in mentally retarded children or very cooperative children. Now, ketamine has become a very popular anesthesia in this pandemic situation. In all the cases, we have to put an intracath and also prepare orally if sedation is required. Surgical steps include incision. The main incision can be made limbal, scleral, or clear corneal. Side port incision can be made by an MVR blade or a side port blades. The anterior capsular axis is usually done manually by rhexis forceps and microrhexis forceps. The other options are vitrorhexis, Clotis, radiofrequency, diathermy, Hugo blade, femto, and septo. The manual CC is different from the adult in the fact that the force is, the pull is towards the center, Trypan blue staining helps in visualization of the anterior capsule and decreasing the elasticity of the anterior capsule. Cohesive viscoelastic is important because they help in flattening the anterior capsule and helping in rhexis. So here I'm showing you a case in which I'm doing anterior capsular rhexis. My video is visible. Okay. So I'm using a microdexis forceps, and it has got markings on the forceps. And actually, you can measure the size of the rhexis using this microdexis forceps. The technique is grasp and re-grasp, and the pull is always towards the center. A small rhexis of 5 to 5.5 millimeter is a good rhexis, and smaller rhexis will cause phimosis, and larger rhexis will cause IOL dislocation or IOL optic capture. So this is another case of a total cataract, and here the rhexis is very difficult. But since we are using the proper technique, we will be able to complete the rhexis. The advantages of using a manual rhexis is a good beam strength. There is lesser chances of radial tear during IOL insertion, lesser chances of decentration, and it is considered as a gold standard. The disadvantage is it is not possible when the capsule is fibrosed and there is a learning curve. So a good hydrodissection ensures good cortical cleanup. A 2 ml syringe with a 30 gauge cannula is being used. Multi-quadrant hydrodissection is done, and it is used to break the corticocapsular adhesions. Usually by the end of the hydrodissection, the nucleus is prolapsed out, and it should be avoided in posterior lenticonus or posterior polar cataract. Cataract removal can be done manually by using the AC maintainer or by automated method like the coaxial or the biomanual. The biomanual offers better chamber stability, and the cataract is so soft it can be easily removed. But the cortical removal is a very important step, and it has to be done very meticulously. All the fibers of the cortex have to be removed, and PC polishing has to be done adequately. Otherwise, there will be a very high-grade post-op inflammation, and also there can be a risk of PCO. So here, sometimes we do get this type of picture in which we find a PC plug sitting on the posterior capsule, and we have to peel this. Using the retro elimination of the higher end microscope helps in these cases. We are cutting these attachments and then peeling from the other side. This type of plaque cataract are quite frequently seen at my center. And then we have to rotate it and take it out. So sometimes this is a thing we can see. This is a posterior capsular dehiscence, grade 2. And for these cases, we have to keep a cutter backup. And so here I'm doing a bimanual vitrectomy. Also, in cases like this, where there is a dense fibrous membrane, we have to do a vitrectomy. So vitrectomy, bimanual vitrectomy offers better chamber stability. Pneumatic cataracts with high cataract are better. Venturi pump is better than peristaltic pumps, and we have to ensure lesser dispersal of vitreous in the anterior chamber, and we can use preservative-free triamcinolone. The intraocular lens, which can be put, are the hydrophobic acrylic, which is a good lens, and a single-piece lens we can put in bag. And if we are planning a sulcus fixation, then we have to use a multi-piece IOL. The age group of 8 to 12 years of pediatric patients are a good candidates for multifocal IOL. The pros is a spectacle independence, but the eye is a growing eye, and myopia in teenager can be expected. We had many secondary refractive surgeries. The cons are halos and glares, less common in more recent design, more sensitive to tilt and decentration, decreased contrast sensitivity. These problems are less common in modern designs, but it is an expensive lens and more prospective trials are needed. The closure of wound can be done with a 10-0 monofilament or a 10-0 vicryl. Advantage of using a vicryl is that it gets absorbed and there is lesser suture-related complications. The post-op care we have already discussed, and actually pediatric cataract surgery is a challenging surgery and it requires a good teamwork, counseling, pre-op and intra-op, post-op. But the social impact is huge, and there is decrease in daily increase in life expectancy, and positive psychosocial impact. With this, I come to an end by a quote, intelligence and capability are not enough. There must also be a joy of doing something beautiful. Thank you.
Thank you so much, Taranum Fatima.
सेम प्रॉब्लम, नर्व्स का प्रॉब्लम है, वो ब्रेन से आंख को एक नर्व आता है, और नर्व थोड़ा पैरालाइज हुआ है, तो पैरालिसिस की वजह से वो डबल दिखते हैं.
Thank you, Dr. Arun. Now I would like to request our chairperson to invite the next speaker. I think Dr. Sujata is ready with her.
Yeah, I think I am ready. Can I share my screen?
Please, ma'am, you can share your screen.
Can you see my screen?
Not yet. It is taking some time.
Yes, yes.
You can see?
Yes, it is visible. Could you please go on full screen, ma'am?
Yeah.
Wonderful, ma'am. You can go ahead. Thank you.
Yeah. So good afternoon, everybody. And since we are going in a reverse order, we have already seen post-operative care, we have seen the surgery, and now we will talk about the pre-operative evaluation. And I'm going to give you a few nuggets of how you evaluate a kid pre-operatively and the differences with adult cataract. So the first thing that you have to know that the child's eye is not a smaller version of the adult eye. So why is it not so? Because it has got associated anomalies. It is a developing visual system. It's a growing eye, and there are lots of tissue differences. So you can't treat the child as a small version of the adult eye. The second difference, say this is a 1-month-old kid with membranous cataract in both eyes, microphthalmos, and he has a heart disease, patent ductus arteriosus. If it was an adult, we would think that we can go ahead with cataract surgery without much of a ado. Now, but for a child, we need to look for systemic links. Talking of systemic links, we need to know the etiology. And for bilateral cataract, only 60% are idiopathic, but the rest 40% have some systemic associations like galactosemia, like infections, the torch infections. However, in unilateral cataract, only 80% are, almost 80% are idiopathic, and very few systemic conditions give rise to unilateral cataract. So what investigations do we need to do for the systemic link? The initial investigations would be full blood count, blood glucose levels, torch titer, and urine for reducing substance and amino acids. If we find any abnormality in this, we go on to the next phase, which are galactokinase levels, serum and phosphorus levels, etc. Now the question is, do we need to investigate every pediatric cataract for systemic diseases? Well, for this child, 2-month-old baby with unilateral cataract and diffuse sutural and punctate cataract with no systemic or ocular associations, we really don't need to investigate. So which are the conditions when we don't investigate? Unilateral cataracts, when there is a history of trauma or a family history, we really don't need to investigate. Now let us see this 6-month-old child with total membranous cataract in both eyes with both eyes nystagmus. How will we manage this case? Now, in an adult, we would probably do an ultrasound and go ahead with surgery. But in a child, the evaluation is a little different. We need to have a history of deviation in nystagmus, which indicates early cataract. We need to do a thorough history for antenatal fever, for birth history, and a family history of any congenital cataracts. Now, the vision evaluation, usually we follow the fixation pattern, a distant direct ophthalmoscopy, cover test, and a examination under anesthesia. A little word about distant direct ophthalmoscopy, which is done at around 1 meter's distance and with the direct ophthalmoscope, and we look for the red reflex. If the red reflex is brightened in both the eyes equally, it means that the child does not have a cataract. If the red reflex is a little dull in one eye, then we actually dilate it and we can easily see a opacity against the bright red background, and we can detect the density of the opacity, the situation, the location of the opacity, and take a decision. We can also do an ultrasound biomicroscopy if the fundus view is not clear, and sometimes a UBM preoperatively under general anesthesia to look for the lens lenticonus and some lens abnormality. Now, some of the poor prognosticators for cataract in a child are complete total cataract with a delayed presentation, strabismus, poor fixation, nystagmus, and other ocular anomalies are also poor prognosticators. Now, another difference with that of adult cataract, before the surgery, we do the examination under anesthesia, and probably it takes a little more time than it takes to do adult cataract surgery. It starts with the inhalational sedative, followed by a keratometry, followed by intraocular pressure. Then the child is intubated, and we go on to measuring the corneal diameter, pachymetry, axial length, gonioscopy. And this is the exact order that we follow for an examination under anesthesia. The keratometry is done first with a handheld keratometer, which corroborates quite well with the manual keratometry without an eye speculum. Then it is followed by the intraocular pressure, which is done as soon as possible after the sedation, before the injection of muscle relaxants, because muscle relaxants can give a false low intraocular pressure. Next comes the axial length. We usually use the ultrasound A-scan. The partial coherence interferometry which is the mainstay now for adult biometry. It is not relevant for adults, for children, sorry. The contact and the immersion techniques are done. The immersion is more accurate than the contact, but all of them has certain areas of error if they're not kept perpendicular or if it indents the cornea. Now, the difference in biometry in children is quite remarkable. Why? Because the child's eye has rapid refractive and anatomic changes. It has a shorter axial length and the steeper K. The biometry is done under general anesthesia and with the child not fixating. And sometimes the cataract is so dense that the axial length breathing does not freeze even in high gains. So biometry is challenging. Next comes to what IOL calculation formula to use. Again, unlike that of adults, where we have moved on to the recent formulas, different literature in the different spans of time have found that the SRK2 and T is more predictable for pediatric patients. What should be the target refraction? Again, there is a difference with that of adults. We aim for hyperopia in children, and usually we keep the patient, we follow the rule of 7, where we add the target refraction and the age should add on to 7. So if the child is 3 years old, the target refraction should be 4. But there is no one rule fits all child. We need to look at other things like the other eye status, the visual acuity of the other eye, parents' refractive error, and then decide on the target post-op refraction. For example, if the parents' refractive error is myopic, then we aim for a higher hyperopia. If we expect poor compliance with glasses, then we don't keep a very high hyperopia. We keep a lower hyperopia, compromising on a myopic shift towards the teenage, towards the later teenagers. So, some of the nuggets which I want to leave you with in a child's pre-op evaluation will be to investigate for etiologies, especially in bilateral cataract. Always see the red reflex. Always do a cover test. Make a note of the refraction. See the fundus. Assess siblings and family members for cataracts. Do a thorough examination under anesthesia, and then decide on the target refraction after a biometry. Thank you. Stop sharing.
Thank you so much, Doctor, for winding it up on time. Thank you, Dr. Sujata.
Thank you.
May I request our chairpersons to please take over the session forward? Dr. Mehul.
Yeah,
Yeah.
we have 5 minutes for question answer. So if we go, I think all speakers are there, then we can talk regarding this. Dr. Tanmay, I think you discussed the management part, but you did not discuss the management part in terms of exophytic and endophytic. If you have a orbital extension of retinoblastoma, and currently we have many methods for the chemo reduction. We can use the chemotherapy for chemo reduction, as well as we have a injection topitocaine retrobulbar can be used for to reduce the size of the tumor as well. And while what are the specific questions to be taken during enucleation of retinoblastoma and targets according to the HP from the optic nerve. That is important, I think.
Yeah, yeah.
Anybody has got a comment? Yeah, tell me.
Yeah, I think long optic nerve sections are very important, and as described well, that we shouldn't, as minimum handling of the tissues is also very important, and inadvertent like perforation of the globe should be avoided at
Correct.
all costs. So those are very important steps to be noted during enucleation.
Secondly, I have a question why there is a cutoff line of 8 years while discussing cataract. I don't seem to understand. If it is 5, then it can be applied to genic age. But
8 years is because it is according to Etiology's rule. After 7 years, you don't see much of progression. So probably to not discuss the undercorrections, they have put it 8 years. I mean, that is my presumption.
I think more vital will be the amblyopia management, which is there. So real drastic difference between the result before 5 years and after 5 years.
I don't think it depends on the age at which you are operating. Because if the kid has congenital cataract, then even if you're operating at 10 years or 4 years or 5 years, it will not make a difference. Mainly because the cataract history is important. So 8 years apart from the growth, I don't see why we should.
It is very important. I think if child has got cataract, if you operate one eye before 5 years and one eye after 5 years more, for 10 years, then obviously other eye will be amblyopia.
I think we were discussing why 8 years has been put, and my comments were regarding why 8 years has been put as to the distinction between why two separate topics was on 8 years and above 8 years. Okay. There are multiple things.
Also, it could be that the need for posterior vitrectomy and a posterior capsular excess also reduces with 8 years of after 8 years.
As the child grows and as he is more cooperative.
Yeah.
And one more factor, like you can have more of this traumatic cases and all in those. That also something like we talk more like 8 years. We are focusing more on the infants, babies, and all. So they must have done that.
Yeah. So any other question? Other chair people can go ahead.
I just wanted to add something in the IL power calculation. I think in our own data, we have seen that axial length is also an independent point when it comes to undercorrection. So we do follow Etiology's rule more or less, except that we change it by around 10 to 12% if the axial length is 2 standard deviations more than for that age group. So very similar to what Sujata Madam is doing, except that we do take into consideration the axial length also.
Yeah, good thought. Yeah.
I think we are almost done.
Right.
So hand over the.
Right, Dr. Mehul Shah. So I would like to take this opportunity to thank all our chairpersons. That's Dr. Mehul Shah, Dr. Vishnu Vahan Prasan, Dr. Manushree Bhate, and Dr. Himalini Samant. And I would also like to thank all our speakers for giving a wonderful presentation. Though there were some technical glitches, but we did a very good presentation today. Thank you so much for attending this session.